So this is 22-year-old woman with a clinical complaint of problematic migraine. She is typically taking paracetamol for this as well as simitriptan, which help, but she is finding headache recur last week. She has history of mild asthma and she takes salbutamol infrequently, but it is otherwise normal, otherwise well. Which of the following is the most appropriate next step in the management? So patient is already taking semitriptan. I think what they are saying, paracetamol and semitriptan, the first line of my for migraine, and she is asthmatic. So other line of therapy would be what? This is their question. So there are three medications you can take with the second line, or you can add them. One is amitriptyline, topiramate, and propranolol. Because patient is asthmatic, with propranolol is contraindicated, and amitriptyline is propranolol also can be, but because of childbearing age, they are saying like this. It's not. So, 65-year-old male patient coming with sudden reduction in vision in his right eye, history of treated hypertension 2 years ago. Uh, 2 years and 2 years history of diabetes on metformin. So, and they give a funduscope. What is the this? So, central retinal vein hypertension, retinopathy, vitreous hemorrhage. So, what is this? This is optic disc. This is artery. What about this flame? Central retinal vein. Patient has relatively sudden onset of blindness and appearance of fundus flame-shaped optic disc. Classical for central. Classical for central vein occlusion. Fundus reveal flame-shaped hemorrhage. 35-year-old woman attending clinic with offensive fishy smell with vaginal discharge. She is 16 weeks pregnant, thus pregnant and thus far the pregnancy has been progressing well. You diagnose bacterial vaginosis. Fishy smell, offensive fishy discharge is bacterial vaginosis. And patient is pregnant. Uh, we are here practice is different, but according to NICE guideline, you have to give oral metronidazole. You have to go through the NICE guideline for obstetric and gynecology. Uh, they are saying first line of treatment is oral metronidazole. So you check it out. Yeah. So, uh, 11-year-old boy is brought to clinic by mother who is concerned with the complaint of headache, last day, fatigue. On examination, appears unwell. Temperature is 38. Heart beat is 90-60 and oxygenation and has nuchal line rigidity, but no photophobia, no rashes. What is the next management? This is also this this is also mentioned in their guidelines. Ring 99 and call emergency. I initially marked give IM benzyl penicillin and then ask them to go to this because obviously this is meningitis. But it is mentioned in their guidelines that if the patient is not that toxic and no no rashes of this, you can because if you not do LP, you won't have the diagnosis and the medications. So it's better to ring and let him go to the emergency. They're saying in rural setting where uh, then IM medications, IM antibiotics. Nice guideline. If you read this with them, you will find it. 16-year-old girl attend clinic with her mother. She had history of anxiety, depression, divorce of her parent 1 year ago, and she is still down, and you feel antidepressant is appropriate, which is the following would be the most appropriate. So, fluoxetine is the first line of treatment if the depression fail in young patients. Children and adolescents, selective serotonin inhibitors considered the second line treatment after counseling is failed. See, nice guideline, moderate to severe. Okay. So these are scenarios, and we have to fit of this. So a 26-year-old male attending clinic complaining of sudden onset of chest pain while playing football. He is SOB, shortness of breath. He was SOB and stopped playing, and then he still has shortness of breath. He's a smoker and occasional smoke cannabis. It's comfortable at rest. There is mild systolic click audible on the left side of the chest. What is the most likely diagnosis? So patient is a smoker and sudden onset with shortness of breath. So this bulla sometimes ruptures and causes spontaneous pneumothorax, and patient usually present like that. Usually helps in comes in healthy individuals and young and healthy individuals. Here I don't know why season is here from August to September, October. There are many cases of many cases of spontaneous pneumothorax will come, complaining of chest pain and shortness of breath. Okay, a 42-year-old man attending clinic, being aware of chest pain 4 weeks ago, he was treated for acute coronary syndrome and underwent 3 vessel stenting. He now complains of central chest discomfort and worsening on inspiration and leaning forward. If we lean forward on this, there is just some fever on examination. Hematocrit heart sounds are normal, though not clearly heard. Was most likely pericarditis because of pericardial fusion post post PCI. You are called to see 82-year-old resident with mild Alzheimer's. So he is suddenly developed breathlessness and he developed quite suddenly. Okay, so temperature, heart rate of 102, blood pressure is okay, respiratory rate is 28. Oxygen, what is sudden which causes shortness of breath in elderly patients? Most likely, if you apply Wells or criteria, so most likely this is hypoxic, the most likely pulmonary embolism. Anxiety will not cause pleurisy, will not cause this short. So you are called on 80-year-old ischemic heart disease present with chest pain. He developed chest pain at night, 8 out of 10, and this he feel nauseated. Last night he had severe 8 out of radiating through the bed. Pain lasted an hour, so he felt nausea in the mission. Is this blood pressure in the auscultation? I marked it ACS, but they are saying this is a dissection of thoracic aorta, most likely. They have given this pericardial graft and sudden oxygen radiating to the back. Dissection of aorta should be on the top differential diagnosis. A 35-year-old woman who is 18-week pregnant present to your surgery with her son nursery age of chickenpox. She is unsure whether she was infected with chickenpox as a child. So before giving anything, we need to check out her varicella antibodies. Check maternal varicella antibodies. A 62-year-old Afro-Caribbean woman attend clinical complaint of widespread bone ache. She is otherwise normal. She returned with alcohol and vitamin D deficiency. So tenderness over sternum can cause this. I will show you in the description. I marked it wrong initially, but this is the answer. And also tenderness over tibia and sternum is a suspicion of vitamin D deficiency. That's how you can check clinically. Laboratory wise, there is levels deficiency, insufficiency, and normal. Deficiency less than 25, insufficiency from 25 to 45, I think. Okay. So vitamin associated with increased amount of osteoids absorbed from water, causing bone and very steady stretching. Typically minister pain applying pressure with thumb over sternum or shaft of tibia. Others like this tenderness over temple is for tenderness over the temples, polymyalgia rheumatica, and this one subcutaneous nodules with gouty arthritis or rheumatoid arthritis at the elbow. Also, Herbender nodes also in uh, rheumatoid arthritis. And in Beckett's disease, you will find bruising over the tibia. 77-year-old woman attend after suffering a fall. She was walking in garden. She described tripping and falling more times. Fall several times in past 6 months. And also have nature causing tripping. She states that noticed gardening and housework is taking longer. She has tremors in her right hand. She was ex-smoker, smoked 10 cigarettes a day. She drinks small glasses of sherry at night. And she has long-standing insomnia. These features are suggested of what? So, what features of her history would be consistent with Parkinson's disease? Age 75. Oh, why? History of smoking will cause tremor for sure, but it all will also cause Alzheimer's disease. Chronic insomnia. Why? This worsening of history of fall is the answer. Parkinson's disease should be suspected in patients presenting with tremors, stiffness, slowness, balance problem, and gait disturbance. The patient has feature of suggestive of Parkinson's disease with tremors and bradykinesis. See again, nice guideline. 50-year-old man being treated for recent diagnosis of hypertension. 2 weeks later, he returned, feeling unwell, being nauseous and fatigued. His blood result is sodium 140, which is normal if you see that range. Potassium is also normal. Urea is elevated, and creatinine is elevated three-folds. So we are saying 2 months ago his urea and electrolytes were recorded normal. So what is the most likely cause of presentation? Drug-induced glomerular sclerosis, focal glomerular minimal change, obstructive uropathy, renal artery stenosis. I marked it red, but renal artery stenosis. The reason is patient might have been prescribed ACE inhibitor, which causes this. Let's see this. The man has acute kidney injury with a history of hypertension, is likely treated with angiotensin convertase inhibitors, which then resulted in ischemic, probably renal artery stenosis. Okay, so that's it.